right, here we are. We're live. Good morning, PTNI's Daily Show here on Facebook, here on Instagram. Sorry for the late start. My name is Alan here on Clinical Tuesday, serving as COO of ICE and faculty member in our fitness athlete division. Getting a late start today. Had some painters coming, had to wait for them to come. And I apologize. This is not going to be the highest quality video or audio. I am out in the garage, so there's going to be some echoing. The neighbor is working on his car, so it's going to be a little bit loud. This is going to be a very visual episode. I've got a body chart here that I'm going to walk us through. So if you're on the podcast and you're a visual person, make sure you jump over to Facebook or Instagram and grab the video. So good morning. Welcome to Clinical Tuesday. Let's get started and rolling with no delay here. What are we talking about today? We are talking about a curious case of kind of a very hidden issue with a patient. So I had this evaluation about a month ago. If you're in virtual ICE, we already broke this case down, but wanted to share it with you all. To me, this case demonstrates the value of the symptom behavior model and why we use this model, because it allows for such great data gathering and a really good test retest, and just the ability to know when things are working and when they're not, and when you need to change the direction to make sure you get the patient the change we want to see. So let's break down this patient and go over the first visit and then go from there. So this patient came in to see me, and she complained of two different symptoms. She complained of medial heel pain and bottom of the foot pain, what she called plantar fasciitis. And she told me it's a constant ache, it never goes away, it's at least a 3 out of 10, and it jumps up to an 8 to 10 out of 10, especially after some aggravating factors. What bugs it? Pretty much everything. Aggravating factors: running, jumping, rowing, biking in the gym, at our boot camp at the gym, and standing at work for longer than 2 hours. So this is a patient that is a nurse and is on her feet 8, 10, 12 hours a day. So that pain is quite severe, and I asked, how long does it take for that pain to come down once it gets calmed down? She said it can take 1 to 3 days. So that's a very highly irritable patient. So this just lets me know I need to be careful with what I'm investigating on this patient. I don't want to flare her up too bad. Easing factors, nothing really here to talk about. Cortisone injections 3 times, no relief. Saw a podiatrist and got an AFO. Again, just kind of marvel at the American healthcare system and how people kind of trip and stumble their way to see us sometimes. So she had an AFO, did not help her, so she stopped wearing it. Ibuprofen, taking a lot of it, 8 by 200 milligrams a day. So she's popping some ibuprofen pills pretty much every couple hours while she's awake, and she's tried icing it, but that did not help either. She also has this concurrent calf cramping in that left calf that is mainly at night and can be kind of relentless, and it is affecting her sleep. Asking her about sleep, getting 5 hours of sleep a night or less due to that heel pain and that plantar fascia pain, as well as the calf cramping. And so highly irritable patient, gathering all of that symptom behavior and just understanding where are the symptoms, where are they coming from, what makes them worse, what makes them better, and how tough can we push this patient, and overall just gathering some other subjective information. We already know her treatment history with the cortisone injections and AFO and that sort of thing, but also digging in deep, finding out very stressful life, has 2 kids at home that she's trying to homeschool due to COVID on top of working full time, and her nutrition is not where she wants it. She finds herself tracking her food but under-eating every single day, and especially under-eating protein, and that is something a common theme that we see among active individuals, is that they're often not eating as much as they should be, and definitely not eating as much protein as they should be. So gathering all that subjective stuff, getting some initial asterisks here of just standing tolerance. That's a big factor for her to be able to stand all day at work. So tracking standing tolerance over time, and then tracking her exercise tolerance, wanting to get her back to box jumps, to running, biking, rowing, jump rope, that sort of thing in a pain-free manner without reproducing these symptoms. So my hypothesis list is kind of being built as we go through this exam. Initially going to some sort of Achilles tendinopathy, some sort of issue in the calf muscle, in the ankle joint. So thinking, what do I want to test there? I want to look at ankle mobility, but also hearing this kind of relentless calf cramping that doesn't change no matter how much we reduce exercise. does put things like claudication and DVT on my radar. So I just want to do some red flag screening there and make sure this patient is not having anything vascular that needs to be referred out before we can dig deeper. So just making sure this patient is appropriate for PT. And then very bottom of my list is something coming from the back with this initial evaluation, but it's very small, right? Never complains of back pain. It says, I've never had back pain. There's that carve getting fixed. Sorry about that. And nothing, numbness, tingling, nothing radiating from my back. I can't remember if I've ever had back pain in my life. So with that kind of report, the low back jumps to the bottom of my list, but it is on my radar. So I have all this. Where do I want to go with this? I want to dig into the ankle, and I want to dig into the claudication and DVT. So I take this patient, I look at her ankle dorsiflexion, and I'm surprised to find that she has excellent ankle dorsiflexion. She has 25 degrees of closed chain ankle dorsiflexion bilaterally, able to touch her knee to the wall and half kneeling, which is surprising. And that kind of makes me question that hypothesis of something in the Achilles. We normally know folks who tend to have trouble with calf pain, with plantar fasciitis, tend to have tight ankles. Break it out further, look at her lateral tibial glide, no issue. Look at her table test, no issue. And so Achilles is on my radar, but it's falling off quickly. Do some Homans testing, some ankle brachial index, some pedal pulses, that sort of thing, and just rule out, I don't think anything's going on claudication-wise. I don't think anything is going on DVT-wise. To really test for intermittent claudication, I do want to get her out on the treadmill and just see, is there a set amount of time, of volume that brings her symptoms back on. But I also know she's a highly irritable patient, right? Going back to that gathering from her initial irritability, I know that her pain can jump to an 8 to 10 out of 10 very quickly, and it can last for days. So even though to truly know, is this an intermittent claudication patient, I just don't want to take her out into the gym and get her on the treadmill and flare her up for like 3 days, right? That's not going to have her come back to physical therapy if we get her out on the treadmill and ruin her legs for the next couple days, knowing she's already stressed, she's getting poor sleep, she's having calf cramps, she's dealing with her crappy kids giving her trouble for homeschooling. I don't want to add any more insult to injury on this initial evaluation. So finding all of that, the thing I tackled was noticing that with a double leg heel raise, she couldn't really do it. She had weak demonstration of range of motion and strength, and it caused that familiar calf cramping and some of that heel pain that she complained of. And so we worked on finding an option for her for double leg heel raises. We ended up coming on 4 sets of 12 with a 3-second hold at the top. And then also teaching her how to just do some toe scrunching to work the intrinsic foot muscles with the wet towel. So that's what we sent her home with after the end of her initial evaluation. Some calf work and some intrinsic foot muscle work to tackle that heel pain and tackle that calf cramping. And so she left, did not really flare her up. She came and left in about the same pain, which for a highly irritable patient like this, to me, was a victory. We did not skyrocket her pain to an 8 to 10 out of 10. She left feeling the same way she did. Obviously, we'd like to reduce that, but with a patient like this, that was a victory to me. And so that was the initial evaluation. And this is why I think we talk about this all the time in pretty much every single course at ICE. We talk about the importance of adopting the symptom behavior model and making sure that you follow it, because the initial evaluation becomes the reassessment. You have your asterisk signs, you know what you're looking at to track change, and it lets you know, is the patient getting better or not? Because if they're truly not getting better, if they are being diligent with their exercises and coming to their appointments, they should be getting better, and you have a system to track that. So with this patient, this was a cash patient, so she could not see me too often. So we agreed to follow up via text and then make a follow-up appointment in 2 weeks. And so tracking her every couple days via text, she is telling me, I am not getting better. The calf raises are getting easier, but my pain has not changed at all. I'm doing the exercises every day. They're getting easier. My calf feels stronger. My calf and my toe muscles are not cramping with the towel scrunch. But overall, I'm really not getting better. My pain is the same. It still bugs me at work. I still can't do all the jumping and running and biking and kind of cardio, high impact stuff at CrossFit boot camp. So really, overall, no change. And so that's my own personal red flag as the practitioner, that I missed something, that we need to get this person back in for an assessment. And that can be scary, right? It sucks. We always say it sucks to suck, right? It sucks to have missed the ball here and not actually found the source of the problem and not showed that patient change, especially a cash patient that is paying, $100, $150 out of pocket. You really want to get it right because you're auditioning for that patient's hour every single time that they come in. So I told this patient, I said, hey, come back in. Let's do a reassessment. I want to make sure I did not miss anything. So I'm going to erase all of this stuff and we're going to start fresh. And so pretty much nothing has changed, right? We've got a reset here, back to visit 1. What am I doing now? Even though this patient never complained of back pain, never mentioned any back pain, said I've never had back pain. I've never had any numbness, tingling, or pain down either of my legs. I've never had any referral of pain from my back. I do want to go back to that initial hypothesis that was very low on my list, that it's something coming from the low back, particularly something, radiculopathy in origin, and really dig deeper into that. And so second visit, this patient comes back. She's able to show me 4 sets of 12 double leg heel raise. So yes, her calves have got stronger. Her muscles are stronger. Yes, that's a little bit of change, but again, her symptoms, her familiar symptoms are not different. So I want to dig deeper into that low back. So what do? I have her go through a couple of assessments. The main thing we look at is we look at straight leg raise. We're going to look at some prone PA with overpressure to her back and see what shows up. And so the first thing I did was lay her down on her back and have her do a straight leg raise. And what did I find? I found on that symptomatic leg, she could only tolerate 9 degrees of straight leg raise before she said, ooh, that's my pain in my heel in my medial instep. That's the pain I feel when I'm trying to jump, when I'm walking on my feet all day at work. That's my exact pain. And the right side also brought on some left side symptoms. She was able to tolerate a little bit more of a straight leg raise. She was able to tolerate 28 degrees. So boom, found something that I should have screened out on the first visit, but did not because it was very low on my hypothesis list. So I missed the ball there, instantly finding very, very sensitive nervous tissue and lighting up her symptoms. So I dig a little bit deeper. I flip her on her stomach. We go through some prone PA. As I'm going through her lower thoracic into her lumbar spine, I hit what I believe to be the level of L3. And when I give her a lot of overpressure, she says, that's my exact pain down in my calf, down in my heel, down in my medial instep. That's what I feel when I'm walking on my feet, when I'm trying to do all of these jumping activities in the gym. That's exactly what I feel. And that's pretty intense. As you push on my back, that's jumping up there pain-wise. So we're onto something, right? Even though this patient has never complained of back pain, has never complained of shooting pain or numbness tingling down that left leg from her back, digging deep into the back, sensitizing the nerve there and giving some prone pressure in the back brought on her familiar symptoms. And so now she's got this kind of zinging pain down her leg. She reports some numbness tingling, which again, she's never ever reported that symptom, even when she's most aggravated. But by really digging in to her back, we've brought on a symptom that she's never complained of. So flip her on her back, give her some manual traction through her ankle, some long axis traction, give her some traction through the hip, and she reports that numbness, tingling, and that pain in her leg is subsiding. So we're on to something very, very good here because we've reproduced her familiar symptoms. And we've also found a treatment to reduce it. So the treatment becomes the homework. So we're out in the gym and we're going to show her how to do some banded traction at home to relieve her own symptoms to her leg. But we're not done here. So finding a way in that we can relieve the symptom, dig deeper, do some dry needling around that level, around the L3 level with some electrical stimulation. And as the stimulation is ramping up, she says, I feel that down my leg. I feel that in my calf, in my heel. It feels warm, it feels nice. It feels like blood is flowing to the area for the first time in a long time. It's feeling really nice. So we leave the stim on for a couple minutes. And then of course, as we do with this model, we go back through the reassessment. I have her stand up and I say, how does the pain in your heel feel? How has it changed? And she's standing there and she says, it doesn't hurt. It feels weird because I always have pain here, but for the first time in a long time, in about 3 years, I don't have any pain in my heel. I think Facebook shut off. Nope, we're good. Okay. So for the first time in a long time, I'm pain-free. So even though this patient never complained of back pain, of any back symptoms, by treating the back, we were able to fix the distal symptom and give her some relief. So now my plan of care looks completely different. We know there's probably not anything wrong with the calf or ankle muscles or intrinsic foot muscles. We know we need to tackle the back. We need to tackle the neurodynamic system. Shout out, if you haven't been listening on Tuesdays, Lindsay Huey has been on here a lot talking about neurodynamics. She did a great presentation at the sampler about neurodynamics and just how important it can be for a lot of patients. So giving her a version of a slump slider that she can tolerate. Again, very highly irritable patient. She could only tolerate just getting in a slump position and just lifting her leg and extending her knee slightly. So I'm just having her budge into her symptoms very, very slightly and then backing off. And again, this is a cash patient. I need to be aware she can't see me very often. So I give her a couple video progressions of, as it's feeling better, how to extend the knee, how to extend the toes and dorsiflex and add more tension into the system, and then how to get the neck involved with some on-off, again, pumping action, using the neck to tension and relax the system as she's able to tolerate it. So give her a complete progression of a lumbar slider for neurodynamics, and she leaves pain-free, which is something she should have left the first visit. But again, the beauty of this model is that she did not come see me 3 times a week for 2 months, 3 months, 4 months without a change in pain. We were able to course correct and get it right on the second visit. And I think it's okay to be wrong. This was a tough case for me because I don't usually miss in this degree of completely not changing a patient's symptoms. But it's cool to be able to look at this and say, this patient is not getting better. Where did I go wrong? Having, my desk in the clinic is stacked up of body charts, and being able to pull that patient's body chart out of the folder, look at it and say, I did these things, but what else could I have done, or where did I go wrong is super, super important, because that lets you track change over time and get somebody back in for a follow-up visit and maybe do something different so that you actually show them change. So don't be afraid to be wrong, but be hard on yourself that you are sure you're doing the right thing, or have the confidence and kind of the humility to say, no, I messed up somewhere, we need to get you back in. And luckily, this patient gave me a second chance and was able to show her some value. A couple days after the second visit, she texted me. She said, hey, it's feeling a lot better. I was able to stand at work for 4 hours before I really started to feel that heel pain. And she has a follow-up visit with me, end of the month, so next week, to see where she's at and progress her even further. So a case I wanted to share with you all, the importance of the symptom behavior model, the importance of looking back at your notes and making sure you did the right thing, or you're not sure, and finding that hypothesis list and seeing what you want to dig deeper into so that you can show that patient change and show them value and get them coming to physical therapy and feeling better. So I hope that case helps. Happy to hear questions, discussion on this. Again, sorry for being late this morning and being out in a noisy garage, but I hope this case study helped you all a little bit, give you some perspective, especially those of you who maybe have not taken a course yet and got introduced to this model. This is how we teach evaluation and reassessment at ICE, and hopefully this case study showed you the value that it can have. So hope you all have a great Tuesday, a great rest of the week. We'll see you all next time. Bye, everybody.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.